Good morning. Today we're going to complete the presentation for pharmacology. In addition, we will discuss all the guidelines related to acute coronary syndrome as well as for CHF and cardiac arrhythmias. Let's talk briefly about pathophysiology and all the signs and symptoms for angina. Angina pectoris is the clinical syndrome of precordial discomfort or pressure, so basically chest pain due to transient myocardial ischemia without infarction. It is typically precipitated, as you know, by exertion or stress and is relieved by rest or nitroglycerin sublingual. Etiology occurs due to cardiac workload and an imbalance between oxygen demand and oxygen supply. It is associated with reversible ischemia. It does not result in permanent damage. So narrowing usually results from arteriosclerosis. This is the most important etiology. This is the reason why in angina you should start statins or any anti-lipidemic medication that we already discussed in the guideline. But also may result from coronary artery spasm because as you know, angina could be stable angina, could be unstable angina, and as well as angina variant, which is also called prismetal. This prismetal angina is due to vasospasm of the coronary arteries. Rarely, angina occurs by coronary artery embolism. Acute coronary thrombosis can cause angina if obstruction is partial or transient. Otherwise, would be an MI. Because myocardial oxygen demand is determined mainly by heart rate, systolic wall tension, and contractility, narrows the coronary artery and typically results of chest pain that is on exertion and is relieved by rest and nitroglycerin. In stable angina, the relationship between workload or demand and ischemia is usually relatively predictable. However, atherosclerotic arterial narrowing is not entirely fixed. It varies with the normal fluctuations in arterial tone that occurs in all people. This is the reason why it does vary and it is intermittent. More people have angina in the morning when arterial tone is relatively high. Also, abnormal endothelial function may contribute to variations in arterial tone. As the myocardium becomes ischemic, coronary sinus blood pH falls to acidic, potassium is lost, lactate is accumulated, and EKG abnormalities will appear. Sometimes the EKG is completely normal. But when there is abnormalities in the EKG, in angina you might see ST segment depression due to ischemia. Left ventricular diastolic pressure usually increases during angina, sometimes inducing pulmonary congestion and dyspnea. Signs and symptoms is reported as chest pain, again, that is produced by exertion and relieved by rest. This chest pain is interpreted or described by the patient as discomfort, heaviness, or pressure. Angina may be a vague but troublesome ache, more rapidly becomes severe with an intense precordial crushing sensation. It is rarely described as a pain, so most commonly is a discomfort. It's most commonly felt beneath the sternum, so retrosternal. Discomfort may radiate to the left shoulder and down to the side of the left arm, even to the fingers, straight through the back, into the throat, jaw, and teeth, and occasionally down the side of the right arm could be seen. Sometimes it's reported as epigastric pain. The discomfort of angina is never above the ear or never below the umbilicus. Stable chronic angina when the paroxysmal chest pain or discomfort is provoked by physical exertion or emotional stress, as I already said, and is relieved by rest and nitroglycerin. Sometimes this presentation is atypical, most commonly in elderly population or female, and is reported as bloating, abdominal distress, or gas sensation. Often ascribes symptoms to indigestion, and this is a common error, and delay for ER presentation or to seek medical advice. Between and even during attacks of angina, physical findings could be completely normal. However, during the attack, heart rate might increase, blood pressure might be elevated, the heart sounds could become distant, and the apical pulse is more diffuse. Angina is typically triggered by exertion or strong emotion, usually persists no more than a few minutes and subside by rest. Response to exertion is usually predictable, but is in some patients exercise that is tolerated once before does not provoke the actual pain. Unstable angina, as we discussed in class, it has many variations as well. Is this stable chronic angina that changes in pattern? So if the angina was produced by climbing two steps of stairs, now is pain is provoked by only combing your hair, for example. Or if it was provoked by walking a block on the street, now it is provoked by only few steps. So that's variation in pattern. In addition, the new onset of diagnosis of angina is considered unstable angina. And the one that you know that is um, not relieved by rest or nitroglycerin. So again, this is the description of the chest pain and the pathophysiology that we already described. In addition, nocturnal angina may occur if a dream causes striking changes in respiration, pulse rate, or blood pressure. Nocturnal angina may also be a sign of recurrent interventricular heart failure, an equivalent of nocturnal dyspnea. Angina may occur spontaneously during rest, and that is also called angina decubitus. It is usually accompanied by a modestly increased heart rate and sometimes marked elevation of blood pressure because of increased oxygen demand. Because angina characteristics are usually predictable for a given patient, any changes, again, rest, angina, new onset angina, or increasing pattern or severity of the angina is considered unstable. It should be considered a serious condition, and such changes are termed unstable angina and require prompt evaluation. Now, what are the modifiable risk factors that you should have in mind and that could produce angina? The non-modifiable, this could be hereditary when you have a first degree relative that has had a CAD or coronary syndrome in the past, and even if they have died at early age. So age, gender, and hereditary conditions. Modifiable risk factors that you're going to target as well besides treatment with medications is discontinue cigarette smoking, treat the hypertension, treat dyslipidemia because arteriosclerosis is the first etiology of the disease, diabetes, obesity, and physical inactivity. Now, the diagnostic criteria, you should do a complete history. That is very important. In addition to that, look at the typical signs and symptoms that we already described. Um, for physical examination, an obese patient has a higher risk for angina. You could also look for fundoscopic examinations to see if you see any hypertensive retinopathy or diabetic retinopathy. Look for changes in vascularity related to hypertension or any signs and symptoms of decompensated heart failure that the coronary syndrome could produce. In addition to that, diagnosis is suspected if chest discomfort is typical and is precipitated by exertion and relieved by rest in the case of stable angina, or new onset and changes in pattern or not relieved by nitroglycerin and not relieved by rest, such as in unstable angina. Or if it's an elderly female that has this type of pain and all the EKGs and stress tests and even coronary angiography is negative, you should suspect a variant or prismetal angina due to vasospasm. EKG, if you look at the EKG, if typical symptoms of exertional angina are present, could be completely normal or again with ST segment depression. In addition, you could see a bundle branch block, which is unusual. Um, Stress tests could be also indicated, more specific than EKG. In addition, you could do echocardiography to be able to determine the cause of this angina. Further testing is needed to confirm the diagnosis, evaluate disease severity, and determine appropriate exercise level for the patient. You could do as well coronary angiography is the standard diagnosis for CAD, but it's not always necessary to confirm the diagnosis. It is indicated primarily to locate and assess severity of the coronary lesion when revascularization is considered, such as percutaneous coronary intervention, a PTCA stent, or a bypass graft such as a CABG. You could do as well a transesophageal echocardiogram. During the angina episode, you could see the paradoxical split of the S2. S1, remember, in pathophysiology is the closure of the atrioventricular valves, and S2 is the closure of the semilunar valves, aortic and pulmonic. Normally, because the left side has a higher pressure than the right side, the aortic valve will close first, and second, in milliseconds of difference, the pulmonary. So normally what you would hear is an A2 and P2, meaning A for aortic and P for pulmonary, in milliseconds of difference. But in angina, you could also see a paradoxical split that normally could occur with inspiration and is diminished with expiration, but in this case could be completely reversible. I'm sorry, backwards. So you could see or hear a P2 and an A2 instead of A2 and P2. We discussed already the diagnostic evaluations. If you do an EKG, most probably what you see is a completely normal EKG with the typical signs and symptoms of angina, or you could see ST depression. That indicates cardiovascular ischemia. Again, echocardiogram to basically rule out etiologies, and exercise tolerance stress tests could also be done, as well as TEE and coronary angiography. Basically, this is to confirm the etiology of the angina. Now, let's discuss about the treatment of angina. And medications that we will be discussing to treat angina will be the ACE inhibitors, the ARBs, beta blockers, calcium channel blockers that we already discussed in the treatment of hypertension, and as well we'll add nitrates and antiplatelet agents. Let's talk briefly about nitrates. Nitrates basically are short acting and long acting. In the short acting, you would see nitroglycerin, which is nitrostat, nitrobid, and nitrolingual. Long-acting, for example, will be isosorbide, which is Isordyl, and isosorbide mononitrate, which is Imdur or Ismo. Indications for nitroglycerin, um, basically it's a drug of choice against the anginal attack, and can be used as monotherapy or concurrently with beta blockers and calcium channel blockers. Nitrates, remember that the pathophysiology for angina is basically to um, ha basically has an imbalance between oxygen demand and oxygen supply. So the nitrates has the ability to reduce the myocardial oxygen demand and reduce the preload, dilating veins and arterioles, relaxing the smooth muscle. So that's the reason why it's one of the first line treatment for angina. Well, since 2007, Chronic Anginas focuses on recommendations about the treatment of angina when the patient has an EF less than 40% and concomitantly patient has hypertension, diabetes, kidney disease. Remember that ACE inhibitors could produce the decreased um, remodeling, and but the problem with kidney diseases is that if you remember in the pre-arteriole of the kidney you have angiotensin converting enzyme, okay, and when the patient is trying to auto-regulate in the presence of hypovolemia or hypotension, the angiotensin converting enzyme at the level of the pre-arteriole vasoconstrict. This is a normal autoregulation that happens when the body has low volume and low pressure. The kidney basically is trying to salvage their own neurons by activating angiotensin converting enzyme and produce vasoconstriction. In those particular patients, when you have acute kidney injury, if you give the patients ACE inhibitors, you basically blunt the autoregulation pathway and the kidney could suffer. So that's the reason why you should not give ACE inhibitors or ARB when the patients are in acute kidney injury. Now, again, this is the first line treatment for angina, and you have the short acting and the long actings that we already mentioned. Now, again, the main mechanism of action of nitrates is dilation of the venous capacitancy. It does produce relaxation of the vascular smooth muscle by stimulating cGMP, which is cyclic guanosine monophosphate, resulting in pooling of blood in the periphery. In addition, decreases preload and decreases venous return, reduces left end diastolic blood pressure and oxygen consumption by producing arterial dilation. Producing vasodilation, in addition, decreases afterload. And most importantly, nitrate will target the specific pathophysiology of angina, which is the oxygen demand supply imbalance. So it does decrease the myocardial oxygen demand and increases myocardial oxygen supply. Now, the main side effects of nitrates would be, of course, hypotension as well as headache. So you have to be aware that if a patient is completely hypotensive, you should not administer nitrates. Vascular resistance is not affected by nitrates, even though afterload is decreased. But pulmonary vascular resistance and cardiac output are reduced. So again, because of this, hypotension could be worsened with nitrates. In addition, 50% of patients with nitrates will experience flushing pounding headache after the administration of nitrates. The headache caused by dilation of the meningeal blood vessels, and usually this appears after several days. If you reduce the dose of nitrates, that should take care of it. Hypotension, again, is due to decreased diastolic filling pressure. And patients, when you discontinue, it could produce a rebound hypertension. So slowly tapering down and discontinue. The dose regimen normally is sublingual tablets with the onset of chest pain, and then every 5 minutes until a total of 3 tablets. Remember that's the protocol for angina. The current recommendation is to take 1 tablet and call the emergency medical assistant while you continue administering your tablets every 5 minutes. Drug interaction, since nitrates produces vasodilation, you should not take this medication in conjunction with other vasodilators. For example, for impotency, sildenafil Viagra and Cialis and Levitra, basically they work at the level of the PDFI, so producing vasodilation. So any vasodilator medication should not be used in concomitant with nitrates because it could produce a profound hypotension and stroke or an MI due to ischemia. In addition, you shouldn't take nitrates with alcohol or with other medications that could produce vasodilation or could prolong refractory period or could produce hypotension as well, including beta blockers and calcium channel blockers. Now, the drawback of nitrates is basically tolerance. And how do you overcome this tolerance? Normally, the tolerance could be seen with the first dose being administered and also after 7 to 10 days of continuous administration. So what you would do is to decrease the occurrence of nitrate tolerance. You would have the patient to have a free interval without nitrate for the total amount of 10 to 12 hours. This is important for your exam. So nitrates, the drawback is that produces tolerance. And this tolerance could be overcome with a free drug period interval to 10 to 12 hours. That is necessary. In addition, for angina, in the guideline, you should administer, if you remember, the morphine, the aspirin, the nitrates, the beta blockers. And after that, you could add the rest, ACE inhibitors, and other medications. So for antiplatelet therapy to avoid thrombosis, because remember, one of the etiologies, even though rare, that could produce angina is the thromboembolic event. So antiplatelets are necessary, and these are aspirin. The mechanism of action of aspirin is prostaglandin synthesis inhibition, which prevent the aggregation of platelets into the endothelial tissue, preventing thrombi formation. You know that the main side effects of aspirin will be bleeding, so you have to look and monitor CBC for the platelets count and also for signs and symptoms of petechia, bruising, etc. In addition, another antiplatelet medication would be Plavix. Plavix will reduce the ADP-induced platelet aggregation. So it has nothing to do with the prostaglandin. It is also recommended for MI and patients that have angina, or patients that have a contraindication for aspirin, or patients that have a device in place, such as a stent. In addition, we have Renexa, which is an anti-anginal agent. It could be used in combination or with nitrates, beta blockers, calcium channel blockers, or ARB. The primary role is basically to relieve the symptoms, but is never the first line of treatment. Now, adverse effect of Ranexia is basically and most importantly the QT interval prolongation, which could produce main AV blocks and even peripheral edema, producing cardiac arrhythmias. Now, again, talking about chronic stable angina, the main treatments are first, modification of risk factors. So, stop smoking, control blood pressure, control lipids with antilipidemics, antiplatelet drugs, which include aspirin or Plavix or Tyclic, that even though it's not commonly used. Beta blockers, nitroglycerin, ACE inhibitors and statins, and revascularization if symptoms persist despite medical therapy. So reversible risk factors are modified as much as possible. Smokers should stop smoking. More than 2 years after stopping smoking, the risk of MI is reduced. Hypertension is treated as the guideline already discussed to be able to increase the workload. Weight loss is also very important, reduces the severity of angina. Sometimes treatment of mild ventricular failure markedly lessen angina. Paradoxically, you could use digitalis occasionally. Aggressive reduction of LDL cholesterol by the dyslipidemia guideline that we already discussed by ATP3 and the new one, that basically improves endothelial function and the arterial response to stress. In addition, you should enforce the exercise program. Walking, for example, reduces the acute ischemic event and improves exercise tolerance. The drugs that we already discussed, first, again, nitroglycerin is a potent smooth muscle relaxant and vasodilator. Its main site of action are in the peripheral vascular tree, especially in the venous or capacitance system, in the coronary vessels. Even severely atherosclerotic vessels may dilate, so nitroglycerin lowers systolic blood pressure and dilates systemic veins. Therefore, reduces myocardial wall tension and oxygen demand. Sublingual nitroglycerin again is given for an acute attack or for prevention before exertion. Dramatic relief usually occurs within 1 or 3 minutes, is complete by about 5 minutes and lasts up to 30 minutes. The dose, as I said, may be repeated every 4 to 5 minutes up to 3 times, but you need to call the fire rescue after the first dose. You could also give nitroglycerin in forms of an aerosol spray. In addition, antiplatelets, again aspirin, binds irreversible to platelets and inhibits cyclooxygenates and prostaglandin, therefore inhibits platelet aggregation. Plavix is a D-phosphate-induced platelet aggregation. They either reduce the risk of ischemic event, but the drugs are more effective when given together. But again, Plavix is always indicated when aspirin is contraindicated. Beta blockers, they limit symptoms and prevent infarction and sudden death, so it is a very good for decreasing mortality. Beta blockers, if you remember, they block the sympathetic stimulation of the heart and reduce systolic blood pressure, heart rate, contractility, cardiac output, and therefore also decrease oxygen demand. They also increase the threshold for ventricular fibrillation. Beta blockers that are available, remember atenolol, metoprolol, and even Coreg and Lopressor. Calcium channel blockers could also be used. they have a negative chronotropic effect. Dialtacen is an example. So those patients that are at risk of beta blocker intolerance, they should not take beta blockers because of asthma, if you remember, unless you choose a cardiac selective beta blocker, such as bisoprolol or metoprolol. You could also use long-acting nitrates, or use if symptoms persist after the beta blocker dose is maximized. So if angina occurs at predictable time, a nitrate is given to cover those times. So you could use azosorbate, nitrate, or dinitrate. So those are long acting. So again, the therapy, first line again, nitroglycerins with beta blockers to prevent acute anginal episode. If you remember, if you have pre-metal angina, then instead you should use nitrates with calcium channel blockers. Second line of treatment, when initial treatment with beta blockers or calcium channel blockers are not effective, after using short-acting nitrates with beta blockers or calcium channel blockers, you could use long-acting nitrates. Remember that beta blockers and calcium channel blockers are used when the patients have variant or pre-metal angina. They have an additive effect, and remember, they suppress all of them, the SA node and the AV node, and could produce not only bundle branch blocks and AV blocks, but in addition, they could worsen myocardial contractility, so they're contraindicated when the patient have an acute exacerbation of CHF. Okay, nitrates also could be combined with calcium channel blockers, such as dialtacen or amlodipine. The third line, patients refractory to 2-drug regimen that may be given a 3 or third drug regimen. Again, calcium channel blockers, beta blockers, or long acting. So again, first line, short acting nitrates with beta blockers, or short acting nitrate with calcium channel blockers, even more in this population that have variant angina. In addition to that, you could add long-acting nitrates, but always remember to use antiplatelet drugs. Now, what do you have to monitor? Basically, signs and symptoms of hypotension, signs and symptoms of bounding headache, and also in addition, remember the tolerance. Follow-up should be done every 2 to 6 months unless the patient has main issues. Patients should be informed and educated of the signs and symptoms of angina or unstable angina in case it worsens. In addition, you should educate the patient as well for myocardial infarction. Now, before we go into heart failure, let's talk a little bit about coronary syndrome, because here includes a guideline for treatment. Remember that acute coronary syndrome results from acute obstruction of a coronary artery. So consequences depend on degree and location of obstruction and range of unstable angina, non-ST7 myocardial infarction, or ST7 myocardial infarction. These symptoms could occur due to an acute thrombi event formed after atherosclerotic plaque has blocked the artery. This plaque could rupture or split, exposing thrombogenic material, activating platelets, and the coagulation cascade. So platelet activation will trigger the membrane glycoprotein 2B and 3A receptors to be activated, and platelets will aggregate even more. Even atheromas causing minimal obstruction can rupture and produce thrombosis. So basically, initially, consequences of this could vary in size, location, and duration of the obstruction. This could be transient ischemia up to infarction. Measurement of markers, biological markers, indicate that some cell necrosis probably occur. So if you check the troponins NCK and CKMB, troponin I more specific. Symptoms of myocardial infarction, again, you would have signs and symptoms of ischemia, which again, if you remember, are the chest pain that is prolonged more than 30 minutes and that is not relieved by rest or nitroglycerin. And if you do an EKG, what you see is that you have either a non-ST systemic elevation myocardial infarction or an ST elevation myocardial infarction. So again, in acute coronary syndrome, you have unstable angina that we already discussed. Is the rest angina that is prolonged, usually more than 20 minutes, either the new onset angina of at least class 3 severity, or increasing angina pattern, changes in intensity, duration, etc. Okay, also you have the non-ST systemic elevation myocardial infarction, which is the necrosis that could occur in subendocardial MI as well. You would see a normal EKG or ST depression, but the biological markers such as troponin I, T, and CK will be elevated. And you have the ST systemic elevation myocardial infarction, which is myocardial necrosis with EKG changes showing ST elevation and also biomarkers elevated as well. Signs and symptoms we already discussed, and diagnosis of acute coronary syndrome, you have to do a serial EKG, that's the protocol and guideline, serial cardiac markers. You would do an immediate coronary angiography for patients with ST systemic elevation myocardial infarction, even more if they have persistent chest pain and elevated cardiac markers and even unstable arrhythmias. You could also do angiography 20 to 48 hours for patients with non-systemic myocardial infarction or unstable angina. So acute coronary syndrome should be considered in either a male more than 30 or a female more than 40, even younger patients with diabetes whose main symptoms are chest pain or discomfort. The pain has to be differentiated from a pleuritic pain of pulmonary emboli, pericarditis, and even pneumonia. That, remember, that is worse with inspiration and cough. The approach is exactly the same: initial and serial EKG and markers measurement. EKG is the most important test and should be done within 10 minutes of presentation. It is the center of decision pathway between either fibrinolytic or taking the patient to an urgent cardiac cath. So if there is availability of a cardiac cath, patient should be taken to a cardiac cath within 90 minutes window, or otherwise fibrinolytics if the cardiac cath is not available. For systemic myocardial infarction, an initial EKG is usually diagnostic, but sometimes it shows ST depression or not at all. You would see in health assessment the different types of myocardial infarction and the leads associated with it. Risk factors should be also target. Remember that these patients with acute coronary syndrome, they have a high risk of heart failure and worsening valvulopathies, so they should be approached quickly. Now, you have to have in mind that there are other causes of troponins being elevated. So besides acute coronary syndrome, you should have in mind that sometimes hypoxia could elevate troponins. So any type of disease that could produce hypoxia. In addition, if you do resuscitation, if you do cardiac thoracic surgery, patients that have heart failure or any advanced cardiomyopathy or any injury to the muscle or renal failure as well. If you do coronary angiography, most often is combined with PTCI stent angioplasty. So patients must be on antiplatelets, Plavix. And the treatment basically is again oxygen, bed rest, low salt, low fat diet. You have to give stool softeners, but the actual protocol for treatment will be the aspirin, um, nitroglycerin on their way to the hospital. So basically, it's designed to relieve the distress and interrupt the thrombosis and reverse the ischemia. It's a medical emergency, so a reliable IV route must be established, oxygen must be given, continuous single lead EKG. Pre-hospital interventions by emergency medical personnel include again the EKG. They have to chew an aspirin 325 milligrams, early thrombolysis when indicated and possible, and triage to the appropriate hospital where primary um, cardiac cath with possible coronary intervention is available. That reduces mortality. If it's not available, then revascularization with thrombolytics. Besides, the cardiac markers test can help identify low-risk patients with suspected acute coronary syndrome. Patient must be in observation in the ICU. In addition to that, again, control hyperlipidemia once the patient is stable, and all the risk factors that we already discussed. So again, aspirin, Plavix, or any fibrinolytic therapy when PCI is not available. You could use beta blockers if the patient is not in overt heart failure. You could use, of course, is indicated an IV drip of heparin, IV nitroglycerin, and also ACE inhibitors and statins when the patient is ready to be discharged unless contraindicated. Now let's talk about heart failure. Remember that it's actually a complication of hypertension. Patients could have a sudden cardiac death after having after having a heart failure. Remember that this is a syndrome of ventricular dysfunction. Left ventricular failure could cause, as you remember, signs and symptoms of shortness of breath, fatigue, and right ventricular failure causes mainly altered mental status, jugular vein distension, abdominal distension, ascites, and peripheral edema. Cardiac contractility and ventricular performance and even myocardial oxygen requirements are affected in CHF. So preload, afterload are also affected. In addition, cardiac output will be if this is left ventricular dysfunction. Remember that most commonly you have left ventricular dysfunction first and then right ventricular dysfunction unless you have primary pulmonary problems. Okay, so if you remember in pathophysiology, what is preload is the loading condition of the heart at the end of relaxation or diastole. So it's basically your venous return, the one that determines the amount of blood or volume that goes to the right side of the heart. And afterload is the force resisting myocardial fiber contraction and is determined by the pressure, by the thickness of the valves that exert the blood or expel the blood outside from the aorta to the systemic circulation. In heart failure, the heart may not provide tissue with adequate blood for metabolic needs, and cardiac-related elevation of pulmonary or systemic venous pressure may result in organ congestion. Remember that you also have two types of classification. You have systolic dysfunction and diastolic dysfunction. You have left-sided heart failure and right-sided heart failure. Systolic dysfunction The ventricle contracts poorly and empties inadequately, leading initially to increased diastolic volume and pressure. And diastolic dysfunction, ventricular filling or relaxation is impaired, resulting in reduced ventricular end diastolic volume. Contractility is normal in diastolic dysfunction. And also, as I said, you have left ventricular failure and right ventricular failure that we already discussed the differences. Now, remember that when you have heart failure, not only the heart itself as a pump is in failure, but also you have other hemodynamic changes, and also renal and RAS is activated. So hemodynamic responses with reduced cardiac output, oxygen delivered to the tissue is maintained by increasing oxygen extraction. So you would have a shift in the oxygen hemoglobin dissociation curve. In addition, you would activate the beta reflexes, increasing sympathetic tone, increasing renin by the juxtaglomerular cells, increasing the release of angiotensin 1 and angiotensin 2, producing vasoconstriction, and also releasing aldosterone for retention of sodium and water, and increasing volume and pressure. Renal response: as cardiac function deteriorates, renal blood flow and glomerular filtration rate decreases. This will affect the BUN and creatinine. So the renin-angiotensin-aldosterone RAS system causes a cascade of potential deleterious lung effect. So normally this is to produce autoregulation and to overcome the lack of pressure and volume. But if it becomes a vicious cycle, it could be worsening for the kidney as well. In addition, you know that there are other neurohormonal responses. You would have activation of catecholamines as well as natriuretic peptides. So patients will release BNP, or atrial natriuretic peptide will be released by the brain and by the right atrium. Etiology of heart failure could be an MI. It could be any type of cardiomyopathies, valvulopathies, cardiac arrhythmias, even patients that have any infiltrative disease such as amyloidosis or hemochromatosis, patients that have severe anemia or overt hyperthyroidism. Signs and symptoms, we already discussed briefly. Now the causes again could be CAD, hypertension, MI, arrhythmias, even pulmonary emboli. Any drugs that could produce the heart failure, we already discussed that calcium channel blockers and beta blockers should not be given when patients have acute decompensated heart failure. Alcohol, endocarditis, myocarditis, and even thyrotoxicosis. Okay, we discussed the difference between systolic and diastolic dysfunction, and remember, you basically have right-sided heart failure and left-sided heart failure, and even more, we have biventricular failure that result from disorders that affect the whole myocardium, such as myocarditis, amyloidosis, or even Chagas disease. There's another classification which is called high output heart failure. This results from a persistently high cardiac output, which may eventually result in an inability of the normal heart to maintain adequate output. Conditions that may increase cardiac output and produce high output heart failure would be severe anemia, thyrotoxicosis, patients that have persistent tachycardia. So cardiac output is high in various forms, for example in cirrhosis of the liver because of high volume. That could produce high output heart failure. And at the end, all the patients of heart failure, if it's not controlled, will end up in cardiomyopathy, either dilated cardiomyopathy or hypertrophic cardiomyopathy. These are all the signs and symptoms of heart failure. You have right-sided heart failure that most commonly have dyspnea, orthopnea, paroxysmal nocturnal dyspnea. You have crackles or wheezes or cough with signs of pulmonary edema with a frothy pink or white sputum. You have Since the volume is in the interstitium in the vascular space, you're hypotensive. So basically, you will trigger the neurohormonal feedback and RAS system again. In addition, you could have, of course, hypoxemia, okay, and fatigue. Most commonly for right-sided heart failure, you would have altered mental status, you would have nausea and vomiting, you would have ascites, peripheral edema, you would have again confusion, altered mental status, jugular vein distension. You have an S3 gallop that, if you remember, S3 is no more than the amount of um, stretching of the ventricle and is produced by an atrial distension or ventricular distension. It's not produced by pressure. It's basically volume overload states. You have hepatomegaly and splenomegaly for right-sided heart failure, and for all of them, right or left, you have a decreased urinary output because of what I explained already about the damage to the kidney um, when you have renal responses to the volume overload. So basically, there's decreased perfusion of the kidney and triggering of the renin-angiotensin aldosterone system to be able to improve that. But if heart failure continues, then progressive renal dysfunction would occur and patients would have cardiorenal syndrome. Okay, these are the left-sided and right-sided heart failure that we already discussed. Now you have classifications of New York for heart failure. You have class 1, that the patient has no limitation for physical activity. They have minimal signs and symptoms of CHF. In class 2, there's a slight limitation to physical activity. They're comfortable at rest, but any ordinary activity will result in signs and symptoms of CHF. In class 3, there's marked limitation to physical activity, comfortable at rest, but in less than ordinary activity. So if the patient gets short of breath here by blocking by walking 1 block, here they're going to get short of breath with minimal activities of ADL, such as taking a shower. And in class 4, there is inability to carry any physical activity, even they have symptoms at rest. That's the main difference between 3 and 4. That minimal activity of LDL, such as combing your hair, will produce shorter breath, but you're okay at rest. And here, even at rest, you have symptoms. Now, let's talk about the actual treatment for heart failure. And basically, before you go into the treatment, you have to concentrate on the physical examination and try to detect all the possible etiologies and target the underlying etiology before you start treatment. So the diagnosis sometimes is only clinical, but if you do a chest x-ray, you might see the vascular changes of pulmonary edema. If you do an echocardiogram, you might be able to see the cardiac arrhythmias or the valvulopathies. You could do a proBNP, even though remember that proBNP is a sensitive factor, but it's not specific. Anything that stretches the ventricle, the ventricular wall, could produce an elevated proBNP, and that includes any cardiomyopathy, includes pulmonary emboli, or any chronic disease in the lung with COPD, bronchitis, etc. So look at the clinical signs and symptoms, look at the chest x-ray, look at the EKG, which is not diagnostic, but sometimes it shows arrhythmias such as left bundle branch blocks or any rapid atrial fibrillation, etc. Echocardiogram, look at the valve function, wall function, if you have left ventricular hypertrophy, any type of pericarditis, any thrombi, any tumor. In addition, you could do again the proBNP. Other tests that you could do, coronary angiography. Treatment is based on, first, before we start the drug therapy, diet and lifestyle changes. Treat the cause and then think about the actual drugs. So immediate inpatient treatment is required for patients with acute or worsening heart failure. due to disorders related to an acute MI, rapid AFib, severe hypertension, or any severe valvulopathy, as well as patients that have a new onset heart failure or patients that are unresponsive to medical therapy outpatient. The primary goal is to diagnose and treat the underlying condition. So, educate the patient on diet and lifestyle modifications such as sodium restriction, appropriate weight, and exercise. Sodium must be less than 2 grams per day. Regular activities such as walking. If the patient has arrhythmia, look for the electrolytes, correct the electrolyte imbalance if it's present. If the patient has an arrhythmia, control the arrhythmia because otherwise the CHF is not going to go away. So we're going to discuss in a little bit the antiarrhythmic medications. In addition, you would see that grades 3 or 4 that have more than 1 year of survival, you should implant it an intracardiac defibrillator. So drug therapies basically is for symptom relief. And you could use diuretics, you could use nitrates or digoxin. Long-term management that improves survival would be ACE inhibitors, beta blockers, aldosterone antagonists, or even ARBs. So in systolic dysfunction, all these drug classes has been studied and has shown benefit. In diastolic dysfunction, fewer drugs has been adequately studied. However, ACE inhibitors, ARB, and beta blockers are generally used to treat diastolic heart failure. So treat the underlying cause, precipitating factors, then you think about drug therapy. Okay? This is for you to understand the RAS system again. Remember that when you have any type of changes in volume and pressure, you release catecholamines. So if you give beta blockers, you will be blunting the effect of the RAS system and improve myocardial function. Then you have the release of renin-angiotensin-aldosterone system. So basically, if there is perceived reduction in circulatory volume and pressure, you will release angiotensin 1 conversion to angiotensin 2. So one of the target of treatment you will see that is ACE inhibitors or ARB. In the sympathetic tone, beta blockers. You could also give arginine vasopressin inhibitors. You could also blunt the effect of salt and water retention by aldosterone. This could be done by ACE inhibitors, diuretics, or also aldosterone antagonists. Okay, so heart failure, remember you have systolic and diastolic. So left systolic dysfunction with an ejection fraction less than 35% to 40% should receive ACE inhibitors. ACE inhibitors and diuretics are the first line treatment for any volume overload. So first give diuretic along with ACE inhibitors. Remember that ACE inhibitors decreases morbidity and mortality. Now let's talk about diuretics. Diuretics are basically given to all patients with symptomatic systolic dysfunction and current or previous volume overload. Dose is adjusted to the lowest dose that stabilizes weight and relieves symptoms. Loop diuretics are preferred, and these are Lasix, Bumix, Metolazone, but most commonly is Lasix and Bumix are given. You could also use thiazide diuretics that work at the level of the distal tubule, but the preferred diuretic is the loop diuretics. They decrease the preload and therefore reduce volume overload. The main mechanism of action we already discussed it in hypertension. Remember that it inhibits sodium and chloride reabsorption at the level of the loop of Henle. So therefore decreases the signs and symptoms of volume overload, including pulmonary edema. In addition, you could use a potassium sparing diuretic. You have to look at the potassium level. Those are spironolactone, for example, and any vasopressin antagonist diuretic. But remember, the best commonly used is loop diuretic. Look for the interactions with NSAIDs. Remember that if you give diuretics, you're going to decrease the volume. You must have the post-renal arteriole intact. Remember that in the pre-renal arteriole you have angiotensin converting enzyme. In the post-renal arteriole you have prostaglandin. Prostaglandin vasodilates in the presence of low volume and pressure. If you blunt the effect of prostaglandin by inhibit them with NSAIDs or aspirin, you would basically blunt the autoregulation and the kidney could decompensate in the presence of diuretics and low volume. Diuretics may also decrease lithium clearance. Remember, if you use thiazide diuretics, the uric acid it could be elevated and signs and symptoms of hyperlipidemia. Remember that Lasix could produce ototoxicity. Now, in addition to that, you could give beta blockers. And beta blockers, you have to be very careful when you have an overt CHF decompensation. So otherwise they're contraindicated. When the patient have asthma, you must use a selective beta blocker, beta 1. They're contraindicated if the patient has a second and third degree AB block, any acute pulmonary edema or CHF exacerbation because they decrease contractility. But if the patient is stable, it's a very important addition to ACE inhibitors, and even more when the patients have chronic systolic dysfunction, and improve survival as well as ACE inhibitors. Carvedilol is a non-selective beta-adrenergic receptor blocker that could be used, okay, and it's the first beta blocker approved for the treatment of heart failure. The primary action, we already know that blunts basically the adrenergic sympathetic response and improve myocardial dysfunction, oxygen demand supply imbalance, and remodeling. So along with ACE inhibitors, they decreased mortality. This is the dose. Metoprolol could also be used. Remember that initiation of therapy with beta blockers may also cause fluid retention, so you have to be very careful. So if you're going to use them, try to use them with diuretic therapy. In addition, we have the ionotropes, which is digoxin, the prototype. Okay, and is highly selective inhibitor of an ATPase system. That's the mechanism of action. So inhibit the action of sodium and calcium build up in the cell, so increasing contractility. So basically this is an ionotrope medication to improve contractility of the heart since the heart is in failure. So as a result, they cause a weak positive ionotropism, reduce sympathetic activity, they block the atrioventricular node, so it's also very good for the use of atrial fibrillation, as you know. But digoxin has no proven effect in mortality, so the only two medications that improve morbidity and mortality are the beta blockers and the ACE inhibitors. So benefits are best when the patient has severe heart failure, but when the patient has severe heart failure and they're in pulmonary edema and they're intubated, instead of digoxin, you're going to use dobutamine and other inotropes that are IV. Okay. Basically, you have to know the signs and symptoms of toxicity. Remember, when the patient have any GI discomfort or weakness, you should think about it. The half-life is 36 to 48 hours. And there are other medications that could reduce the clearance of digoxin, and we will see this in antiarrhythmics. So quinidine, amiodarone, verapamil, which is a calcium channel blocker, along with dialtazine. Okay, so you need to know the signs and symptoms of digoxin toxicity. The most common is GI discomfort. So if the patient complains of nausea, vomiting, anorexia, or diarrhea, you must suspect digoxin toxicity if the patient is on digoxin medication use. In addition to that, they could have CNS manifestations, yellow vision, they could have proarrhythmias, they could have bradycardia, and blocks. So you have to monitor the signs and symptoms of toxicity. The levels, this occur when the levels are greater than 2 milligrams per deciliter. Monitor potassium level. It's not that the digoxin decreases potassium level, but when the patient have hypokalemia, the chances of having arrhythmias are increased. Okay, so monitor the signs and symptoms of toxicity and never give digoxin when the patients are bradycardic. In addition to that, we have vasodilators that could be used for the treatment of CHF. Those are hydralazine or isosorbide dinitrate, may help truly intolerant patients to ACE inhibitors or ARB. So if the patients are intolerant to ACE inhibitors or ARB, or there's a contraindication, or if the patient has significant renal dysfunction, for example, you could use hydralazine. Although it has a long-term benefit, combination with beta blockers, for example, is good. They produce venodilation. They redistribute blood volume to the venous side of the heart, away from the lungs, so therefore decreasing preload. Now, what will be the actual guideline for treatment? For stage A, remember you have one so for patients that are in stage A, ACE inhibitors are the drug of choice along with diuretics, and ARB as well if the ACE inhibitors are contraindicated. For stage B, ACE inhibitors in all the patients, ARB if ACE inhibitors are contraindicated, and beta blockers, of course, must be used along in all the stages unless the patient has a contraindication or there's an over CHF exacerbation. In stage C, ACE inhibitors and beta blockers. Remember that if the patient has volume overload state, even though diuretics are not listed in stage A or B, diuretics must be used for volume overload state. In addition, digoxin could be used. And in stage D, if you remember the New York classification, the same as stage C along with ionotropes. So this patient will be severely decompensated, and you will see that instead of digoxin, you will be using IV dobutamine, and this patient is, of course, in the hospital. There is a need for ventricular assist device when patients are in stage 4, but if they have more than 1 year survival. Otherwise, hospice is recommended. Now let's talk about cardiac arrhythmias, and that will be the last topic of presentation. The normal beat is regular, is coordinated, because electrical impulses generated and spread by myocytes with unique electrical properties. They trigger a sequence and organized myocardial contractions. Arrhythmias and conduction disorders are caused by abnormalities in the generation of conduction. So any heart disorder, including congenital anomalies, any channelopathy, any electrolyte imbalance, any hypoxia, any hormonal imbalance, even drugs and toxins could produce arrhythmia. So you have to look at all that. So basically, it's the result from a structural and electrical conduction system that may compromise cardiac function. You have to look at MI, CHF, any hypotension, any valvular disease could produce it, hypoxemic, hypercapnia, thyroid abnormalities, electrolyte disturbances, drug toxicity, and even alcohol and anxiety. So you have to look for all these causes before you start medication and try to treat the underlying condition. So basically, the passage of ion across the myocyte cell membrane is regulated through specific ion channels that causes the action potential to be activated. So you have depolarization and repolarization. The action potential over working myocytes begins when the cell is depolarized from diastolic, less than 90 millivolts, and to a potential of minus 50 millivolts. If you remember this in pathophysiology, the threshold potential is basically producing sodium channels to open, causing rapid depolarization, and also the fast sodium channel is rapidly inactivated as the potassium channels will open, allowing calcium as well to enter the cell. At first, these two processes are balanced, maintaining a positive transmembrane potential and prolonging the refractory period of the action potential. During this phase, the calcium entering the cell is responsible for electromagnetical and myocardial infarction. So eventually calcium influx ceases and potassium efflux increases, causing rapid repolarization. As you would see, these are the phases of the action potential that all the antiarrhythmic medications will target. So while depolarized, the cell is resistant. You have refractory, absolute refractory period being initiated. Subsequent depolarization is not possible. So after partial but incomplete repolarization, a subsequent depolarization could occur, and that's the relative refractory period. So all the antiarrhythmic medications will basically target the action potential phases and also will prolong the refractory period. Okay. Now, what is absolute refractory period? I already discussed. This is basically regardless of the strength of the stimuli, the cell cannot depolarize again when the action potential is going through depolarization, so the entrance of sodium. And relative is that it could be depolarized again during repolarization. Now, you have a spontaneous cells that depolarizes. You have the SA node that conducts to the AV node, that conducts to the bundle of His, and then to the Purkinje fibers, and then to the bundle branches. The heart has the ability to spontaneously trigger action potential and depolarize, and that is called automaticity. There's no need for the brain to start triggering action potential at the level of the heart. This is the only organ that does not need an impulse from the brain to start muscle contraction. So if this is altered by either cell damage or biochemical disturbance or any drug or any toxins, arrhythmias will occur. You could have arrhythmias due to reentry arrhythmias. You could have fast channel tissues, depolarization. So basically, rhythm disturbances result from abnormalities of impulse formation, impulse conduction, or both. Bradyarrhythmias result from decreased intrinsic pacemaker function of the SA node or the AV node or even the Purkinje fiber. Reentry is the circular propagation of an impulse around two interconnected pathway with different conduction characteristic and refractory period. Atrioventricular nodal reentry is used as an example. Two pathways are connected. A normal impulse arrives to one point. Conduction through pathway is low. In another one, there's a premature impulse that will find a different pathway, but the normal pathway is blocked. If conduction over one pathway is low, a premature impulse may continue retrograde all the way to another point, bypassing refractory period. So basically, continuous cycle will send an impulse to the ventricles, provoking reentrant tachycardia. The impulse can return to the initial point and bifurcation could occur. It could also be a short circuit conducting tissue that could occur, producing premature contraction. So if the reentry is repetitive, patients could have sustained ventricular tachyarrhythmias. Type of arrhythmias, you could have supraventricular tachycardias or ventricular tachycardia. Supraventricular tachycardias are above the bundle of His, and here you have the sinus tachycardia, the sinus bradycardia, the paroxysmal supraventricular tachycardia, rapid AFib, rapid A-flutter, and even PACs are present in supraventricular tachycardia, as well as Wolff-Parkinson-White syndrome. You have at the bundle of His junctional arrhythmias that patients would have non-paroxysmal AV junctional when the heart rate is greater than 60, or junctional when the heart rate is 40 to 60. You could have premature junctional complexes, AV dissociation, even first degree AV block and second degree AV block is present as junctional. Ventricular tachycardias, you have the PVCs, you have ventricular tachycardia, ventricular fibrillation, and torsade points. Now, let's talk about the antiarrhythmic medications. There are different classifications. You have class 1 drugs that here you have class A, B, and C. For example, in class 1A, you would have the quinidine, procainamide, and disopyramide. The class 1 agents comprise the standard membrane stabilizing. These agents work by selectively blocking the fast sodium channel and depressing phase 0. So if we come here to the phase 0 of the action potential, is basically the phase of depolarization that results in decreased conduction velocity. The class 1 classifications are local anesthetics, so they could be used as well in anesthesia. In addition, class 1 increases the threshold of excitability and decreases the rate of spontaneous phase 4 depolarization, which is the actual resting membrane. So class A lengthens the duration of the action potential, class B shortens the duration of action potential, and class C minimally increases action potential. Then you have class 2, which are the beta blockers, class 3, which are potassium channel blockers, and here you have the amiodarone, which is your prototype, and class 4, you have the calcium channel blockers. So these are the phases. You have phase 0, which is basically your depolarization. You have phase 1, which is not related to repolarization, but there is an exchange of sodium and potassium. The 2 is the repolarization, and 3 and 4 are basically going back to the resting membrane. Class 1A, for example, you would have mainly depresses the phase 0 of the action potential. So decreases depolarization, but mostly repolarization. Class 1B also targets the phase 0 of depolarization, having changes, of course, in the repolarization phase as well. Class 1C, all of them, as you could see, class 1 targets the phase 0 and slows the conduction of the SA node and AV node, but has minor effect on repolarization. So class 1 compared to B and C, class 1 has higher prolonged repolarization compared to the rest. Examples of class 1 is quinidine, procainamide. As you would see, class 1B is lidocaine, is an anesthetic. You have dilantin at this level as well. Class 1C is flecainide and propafenone. Class 2, you have the beta blockers, all of them. Class 3, you have amiodarone, sotalol, bretylium. And class 4, you have the calcium channel blockers. So normally you're not going to prescribe these medications outpatient. You have to work in collaboration with a cardiologist, but you have to know the main pharmacodynamics and pharmacokinetics of these medications. You would see these patients, for example, if they have infection, depression, anemia, any thyroid problem, any electrolyte imbalance that produced this type of arrhythmias, you would basically refer them. Now let's talk about class 1 classification. It's related, for example, quinidine is related to the anti-malarial drug quinidine. It has efficacy against supraventricular and ventricular arrhythmias. It is useful in the treatment of reentrance arrhythmia, such as in atrial fibrillation. It is a broad spectrum antiarrhythmic. It slows the conduction velocity of phase 0 and prolong the other phases. So you would see that the major effect is producing QRS complexes, widening and prolonging QT. So you have to monitor EKG with this medication. Quinidine has an anticholinergic effect, so you might see signs and symptoms of everything dry or everything fast as well. It could cause torsade points. It could produce cardiotoxicity that may result in AV block and ventricular arrhythmia. It has an atropine-like effect, so you have to monitor everything dry and everything fast. It could cause vasodilation and GI side effect, so monitor EKG is prevalent. It could produce what's called synchronism, and synchronism signs and symptoms are basically tinnitus, blurred vision, and headache. May interact with other medications that activate the cytochrome P450, such as ketoconazole, such as erythromycin, calcium channel blockers. In addition, you have to monitor signs and symptoms of liver toxicity. So again, GI upset and abdominal pain and cramping are the most common side effect of this medication. Synchronism is a constellation of adverse effect that again is characterized by tinnitus, hearing loss, headache, vertigo, dizziness, disturbed vision, etc. Now, life-threatening adverse effect that you have to look for: EKG. Look for worsening of heart failure. Look for heart block, thrombocytopenia, agranulocytosis, acute hemolytic anemia, and even torsade point. Now, procainamide affects cardiac automaticity and excitability, responsiveness, and conduction. Is similar to quinidine. However, its effect on the autonomic nervous systems are significantly weaker. So this medication has no anticholinergic properties. Is rapidly absorbed and is protein bounded as well. Is extensively biotransformed by the liver. Okay, the only available form is IV solution. Procainamide is contraindicated for the use of patients with hypersensitivity to the medication, and also for patients that have blocks such as bradycardia, AV block, worsening heart failure, and hypotension. This might be a question of your test. Okay. In addition, you have disopyramide, which slows conduction velocity in phase 0 as well as the others. Is used for the treatment of SVT and ventricular arrhythmias. Now, this one has also anticholinergic properties. Everything dry and everything fast. So It's used to treat atrial fibrillation and must be given along with beta blockers and calcium channel blockers because of the pro-arrhythmic effect that could occur. It is also contraindicated for patients that have overt CHF exacerbation and left ventricular dysfunction with an EF of 40% or less. Now, you also have class 1B, which is lidocaine, your prototype. Is used predominantly for emergency treatment of ventricular arrhythmias. Lidocaine has minimal effect on the autonomic nervous system. It counteracts arrhythmias in abnormal Purkinje and ventricular fibers without affecting normal cardiac tissue. So it decreases automatic conduction and shorten refractoriness. It suppresses automaticity as well. It's used for the treatment, again, as I said, emergency treatment for ventricular arrhythmias. Now, main adverse drug reaction, because it's an anesthetic, it produces CNS, dizziness, lethargy, paresthesias, etc. We also have mesicletine. It's an analog of lidocaine that is used to treat ventricular arrhythmias as well. Is after oral administration, it undergoes minimal first pass effect, and potential adverse effects are also GI disturbances and tremor, and also dizziness because it's an anesthetic. We also have phenytoin or dilantin, which is a class 1B drug. This is a limited spectrum of antiarrhythmic activity. It's primarily used for the management of digitalis-induced arrhythmias because it abolished digitalis-induced abnormal automaticity. Then we have class 1C, which you have flecainide and or tambocor. Flecainide is also a potent blocker of the sodium channels and the phase 0. It's used for severe refractory ventricular arrhythmias, ventricular tachycardia, paroxysmal ventricular tachycardias, aflutter, and AFib paroxysmal. It has to be used in the hospital. It's not for use of primary care. Basically, what it does is primarily block the inward movement of sodium through the fast sodium channels of the myocardial membrane, so spontaneous depolarization is decreased. It's not as effective as preventing mortality in life-threatening ventricular arrhythmias. The drawback of flecainide is that patients must be monitored with an EKG for at least 4 hours after infusions because it could precipitate cardiac arrhythmias, it could worsen heart failure. Then we have propafenone, which is another medication that is used for class 1C. It's for the treatment of SVT, such as atrial fibrillation, and of course, since it blocks the SA node and sodium channels entrance in the phase 0 of depolarization, will produce bradycardia, heart block, and one of the most common side effects will be a metallic taste and GI discomfort. As well, can lead to exacerbation of heart failure. Then we have class 2 medications, which are the beta blockers that we already discussed in hypertension. Basically, remember, is the beta adrenergic receptor blocking agent. Propranolol is your prototype. It's a competitive and non-selective beta 1 and beta 2 receptor blocker. Okay, basically what they do is it's for the treatment of supraventricular arrhythmia, sinus tachycardia, and atrial fibrillation and flutter. It slows the conduction of AV node. Then you have class 3 antiarrhythmics, which your prototype is amiodarone, even though we could use ibutylide, Corvert, or sotalol. In class 3 antiarrhythmics, we have the prototype amiodarone. Amiodarone is very important for you to know that it's for the treatment of ventricular arrhythmias, and amiodarone is indicated only for recurrent ventricular fibrillation and recurrent hemodynamically unstable sustained ventricular tachycardia. All of them prolong the action potential and refractory period in the Purkinje fiber. It's also important to know that amiodarone decreases myocardial oxygen demand and enhances cardiac performance, relaxing vascular smooth muscle and decreasing systemic vascular resistance. It's also important to know that amiodarone contains an iodine nucleide, so that produces an inhibition of the thyroid hormone, so it could cause either hypothyroidism or hyperthyroidism. In addition, amiodarone could worsen heart failure and could worsen or produce pulmonary fibrosis and pneumonitis because the medication could induce pulmonary toxicity by hypersensitivity pneumonitis. It potentiates the adverse effects of Coumadin, so INR has to be monitored when the patient is in amiodarone. Then you have Drodenone is also approved for supraventricular tachyarrhythmias, AFib, and A-flutter. It's structurally related to amiodarone, so iodine has to be in mind for thyroid toxicity. It's also high cytochrome P450, but it doesn't have interaction with warfarin. You have sotalol that even though it's in class 3 classification of antiarrhythmic is also a beta blocker. It's used for supraventricular tachyarrhythmias and ventricular tachyarrhythmias. Now, sotalol is important to know that it's the first line consideration in the treatment of malignant ventricular arrhythmias, including Wolff-Parkinson-White syndrome. Sotalol prolongs the action potential and QT interval, so decreases automaticity. Then we have ibutylide that is related to sotalol, but it has no blocking activity. The most common indication for ibutylide is for the termination of atrial fibrillation or atrial bladder. So restores sinus rhythm in approximately 50% of patients with this arrhythmia. Is used as cardioversion medication-wise. Ibutylide, the most common adverse effect is ventricular extrasystole and ventricular tachycardia. So patients also have to be monitored 4 hours EKG after giving this medication. And the class 4 antiarrhythmic medications, we have the calcium channel blockers that we also already discussed in hypertension. They inhibit the entrance of calcium into the cell or inhibit its mobilization from the intracellular store in both cardiac and smooth muscle. So cardiac and vascular smooth muscle depend on the calcium for contraction. In addition, specialized cardiac tissue capable of automaticity and AV conduction dependence of calcium entry and mobilization for depolarization will be affected. So the main cardiovascular side effects of calcium channel blockers, and remember in hypertension we discussed the non-dihydropin are the one used for cardiac arrhythmias. The dihydropins are used for hypertension. So for the diltiazem or verapamil, which are your prototype, are for the treatment of SVT and reentrance tachycardia, including AFib and A-flutter. And the miscellaneous classification, we have digoxin that we already also discussed in CHF. Now, in other miscellaneous, we also have adenosine. And adenosine is used for paroxysmal supraventricular tachycardia, is an unclassified antiarrhythmic, Adenosine is natural occurring component of the body cells. So it's an important physiological mediator for organs. It is produced in the myocardial cells by the CAMP. So adenosine activates potassium channels and increases the outflow of potassium current for repolarization. So adenosine works at that level. And you know that adenosine is also given for supraventricular tachycardia treatment and for the diagnosis of atrial fibrillation to distinguish between AFib to a flutter. In addition, we have atropine sulfate, which is a parasympathetic drug that enhances nodal automaticity and AV conduction as well. It's for the for the treatment of symptomatic bradycardia. But as side effect, it could produce tachycardia. Now, for AFib and a flutter, the first line of treatment would be what? If the patient has severe hypotension, syncope, heart failure, or angina, so patient that is hemodynamically unstable, the first line of treatment will be direct current cardioversion. If the patient is hemodynamically stable, you do this first. If the patient is hemodynamically stable, then you could give IV dialtosan, verapamil, or beta blockers. Remember that beta blockers must be used in caution if the patient has overt CHF decompensation or if the ejection fraction is less than 40. In addition to that, you could use IV dioxin or amiodarone if there is signs of worsening heart failure. So the second line, if you do cardioversion and the arrhythmia persists, remember that you must use anticoagulation therapy. So if it's the new event and the patient could be cardioverted and converted into a normal sinus rhythm within 24 hours, there is no need for anticoagulation. After 48 hours, the patient must be in anticoagulation therapy to prevent thrombosis. The third line for AFib and F flutter, if the patient is in permanent AFib or F flutter, rate control plus anticoagulation therapy. So again, you come here and you do beta blockers or calcium channel blockers plus anticoagulation. For paroxysmal supraventricular tachycardia, if the patient is hemodynamically unstable, again, you synchronize. First, have the patient produce vagal maneuvers, so tell them to cough or to push. For paroxysmal supraventricular tachycardia, second line is IV adenosine. If the patient persists, then calcium channel blockers, or you could give prokinamide or amiodarone. Third line of treatment, you could do ablation therapy, or you could add digoxin as well to the prior medications used. For PVCs, first, treat the underlying cause. Look for electrolyte imbalances. Look for thyroid problem. There is no systolic heart disease and the patient is asymptomatic or symptoms minimal. There's no over CHF. You could give beta blockers. If the patient is symptomatic, again, and there is systolic but minimal heart disease, beta blockers. Remember that beta blockers and calcium channel blockers are contraindicated when the patient has an overt CHF. Now, post-MI, we already discussed it in angina and unstable angina and myocardial infarction. Now, sustained ventricular tachycardia, the first line, if the patient is hemodynamically unstable, you do cardioversion. Otherwise, you do IV prokinamide and amiodarone or IV sotalol. Otherwise, IV lidocaine, ICD placement must be considered. Pulsus ventricular tachycardia, you have to follow the CPR, defibrillation algorithm. First line for bradycardia, again, if the patient is completely asymptomatic, observation. If the patient has signs and symptoms of hypoperfusion or hemodynamically unstable, you give atropine. If atropine is ineffective, then pacemaker. Now again, do not forget to monitor for etiology. Underlying etiology is the first initial approach. Monitor rate and rhythm, monitor blood pressure, and also side effect of the medication. And this is the end of this presentation.